problems. And now we go on to the next talk by regarding the posterior capsular issues and capsular phimosis by Dr. Sandhya. Dr. Sandhya is a senior consultant at Giridhar Eye Institute, Cochin. She's a prolific cataract surgeon and also a UVA consultant. Over to you, Dr. Sandhya.
Thank you, Dr. Soni. So I'll be dealing with posterior capsule issues and capsular phimosis. So this 70-year-old gentleman underwent phacoemulsification with multifocal IOL implantation. Post-cataract surgery, his unaided visual acuity was 6.6 and 6, but he complained of tailing of light. So examination, the multifocal IOL was well centered with the uniform overlap of capsular axis all around, and the anterior chamber was quiet. But there was a linear fold on the posterior capsule which was causing these symptoms. And after YAC capsulotomy, he was relieved of symptoms. Now, the capsular folds or wrinkles are mainly of two types. The first type is the broad undulations of clear capsule, which are common in the early postoperative period before the capsule tenses. And posterior chamber intraocular lens also can induce broad wrinkles along the axis of the haptic, but they rarely produce any visual disturbances. However, some patients can complain of linear distortion. In contrast, fine wrinkles due to capsular fibrosis, they occur late in the postoperative period and they produce marked optical disturbances. And visual disturbance due to either early or late capsular folds or wrinkles can be treated with capsulotomy. Now this patient, post-cataract surgery, had 6.6 vision, but he complained of glare and increased light sensitivity, especially at night. And this was his presenting complaint before surgery, and the surgery did not produce any difference. And he had early posterior capsule opacification, and he was treated with capsulotomy and he was happy. But before doing YAC caps, we should rule out other causes of glare and increased light sensitivity like ocular surface disease or the multifocal IOL itself, because a YAC capsulotomy can complicate the explantation of the multifocal IOL if that is the cause, if the need arises in future. Now the PCO can be of two types. The fibrous type is due to abnormal proliferation of lens epithelial cells, and the pearl type, which is the commonest type, is due to normally differentiated lens epithelial cells. And this 76-year-old lady underwent phaco 1 year back, and she complained of blurring of vision, and her best corrected visual acuity was 6.9 parts N8. And there was this cloudy appearance in the pupillary area. The intraocular lens was well within the back, and the capsular axis was uniformly overlapping the IOL optic. On slit examination, a cloudy fluid was present between the intraocular lens and the posterior capsule, and anterior segment OCT showed hyperreflectivity between the intraocular lens and posterior capsule, and this was capsular back distension syndrome. Capsular back distension syndrome is invariably associated with in-the-bag IOL placement, and the capsular axis is relatively smaller, and it overlaps the IOL optic all around and will stick to it. So the residual lens epithelial cells, when they proliferate and produce extracellular matrix and collagen that accumulate between the lens and the posterior capsule, and later on it becomes cloudy and produces causes reduction in visual acuity. And so the diagnosis in the early stages can be made by AIOS2025 and UBM, but when the patient becomes symptomatic, a slit lamp examination can clinch the diagnosis. And after YAC capsulotomy, the turbid fluid was released into the vitreous, and the patient had a good visual acuity. Now, in the undilated position, this can be confused with dense posterior capsule opacification or IOL opacification, but a dilated examination will help in differentiating these conditions. And the differentiation is important because in CBDS and PCO, capsulotomy is the treatment of choice. But in lens opacification, if you do capsulotomy early, then the explantation will become difficult. Now, though this patient had 6.6 vision, the quality of vision was poor because of the presence of vitreous in front of the IOL. And then how can we prevent the posterior capsule related issues and PCO? So you should make a good capsular axis which will uniformly overlap the IOL optic all around, so that it will have a shrink wrap effect on the over the IOL optic, protecting it from the harmful macromolecules within the aqueous. And the hydrodissection should break all the capsulocortical adhesions, and you should remove the cortex completely. Now this square truncated edge of the modern IOLs, it will prevent migration of the lens epithelial cells from the equator to the center, reducing PCO. And also the in-the-back placement of the IOL will prevent adhesion between the anterior excess margin and posterior capsule. And also a good capsule polishing will remove the residual lens epithelial cells, reducing PCO. Now coming to capsular phimosis, there is progressive contraction and fibrosis of the capsular excess margin, potentially obstructing the visual axis, and also it can produce late IOL changes like pseudophacodontitis, IOL tilt, decentration, or even subluxation or dislocation because of progressive zonular weakness or dehiscence. Now it is due to the metaplasia and fibrosis of the lens epithelial cells at the capsular excess margin, and this is exaggerated by the imbalance between the centrifugal forces and the sphincter effect of the rhexis margin. And the smaller capsular excess, zonular weakness, advanced age, and high myopia are all risk factors for the development of capsular phimosis. It can be reduced by making a larger capsular excess and also by meticulous lens epithelial cells cleanup at the time of phacoemulsification. A can-opener capsulotomy rather than a continuous curvilinear capsular rhexis is associated with less incidence of capsular phimosis. Now, as told, it can be asymptomatic or there can be progressive diminution of vision. Glare halos or monocular diplopia will be there when the lens is grossly descended, or when it is dislocated, there can be sudden loss of vision. Now, in this patient, he had a pseudoexfoliation, and then there was a increased gap between iris and the cataract, indicating some zonual weakness. And as you can see here, when the rhexis was initiated, the entire lens back complex was moving, suggestive of zonual weakness. And the lens was nudged after hydrodissection. The capsular rhexis came to the center. That again points to zonual weakness, and the entire capsular bag was shaking during emulsification. And I had to keep this Sinskey hook behind the phacoprobe to prevent aspiration. So identifying these signs of zonual weakness intraoperatively is important so that we can take proper precautions and can prevent the occurrence of capsule phimosis and decentration of IOL. So in this patient with severe zonual weakness, CTR was placed inside the bag, and a 3-piece lens was injected into the anterior chamber, and the haptics were carefully placed in the sulcus, and the optic was taken under the rhexis margin and captured. So the CTR will expand the capsular fornix, and the 2 haptics in the sulcus will give extra anchorage to the lens, so preventing its decentration. Now in this patient, during phacoemulsification itself, CTR was used, and then once the IOL was implanted, I felt the rhexis was small, so multiple radial nicks were made using a micro-rhexis scissors so that the capsular rhexis opens up and the sphincter action is less. So there is less chance of capsular phimosis. Now this patient had mature intumescent cataract, and the rhexis was done in 2 stages. And when the IOL was inserted, the haptic was folded and there was eccentricity of the rhexis. So it was enlarged after the insertion of IOL so that the forces acting on the rhexis margin becomes uniform. This patient had posterior capsule opacification and capsular phimosis. So at first, an opening was made on the posterior capsule using ND-arc laser, and then multiple radial nicks were made on the anterior rhexis margin so that the rhexis margin opens up and there is no progression for capsular phimosis. This video was given by Dr. John. And in this patient, progressive capsular phimosis and zonular weakness has got decentration of the IOL bag complex. So this is more common in patients with pseudoexfoliation as mentioned previously. So in such cases, we need to explant the IOL bag complex, and we'll have to do some form of secondary IOL procedures like iris glow as seen here, or any other form of scleral fixation to restore vision. Now to summarize, suboptimal visual outcome in spite of normal sentinel's visual acuity is not uncommon due to various capsular issues, and it is important to identify them and treat accordingly. Thank you.
Thank you very much, Dr. Sandhya, for that very illustrative talk with excellent videos on how to prevent and how to deal with